Thanks, Kanika. Thanks for inviting me to this wonderful instruction course. So good morning, everyone. So I'll be talking on differentiating toxoplasma and viral retinitis. So I'll just, for the audience, if you have any question, if it remains unanswered, or you are watching the recording later in YouTube or some other social media, mail me. You can mail your query to me. This is my email ID. I'll be happy to answer your query. So to start with, I'll start with the case. A 30-year-old female, she complained of floaters for 20 days with diminution of vision for 10 days. And she also had a history of fever 1 month back. The serology carried out during the febrile illness was inconclusive, and the physician treated her as a case of viral fever. So when she went to a local ophthalmologist, you can see the fundus photograph here. The patient was diagnosed as neuroretinitis or query viral retinitis, started on acyclovir and oral corticosteroid for 2 days, and the patient was referred to us. As you can see here, the referral doctor actually thought it as a minimal hyperemia, and there was a patch of retinitis, and the hard exudates were scattered as an incomplete macular fan. So on examination, her visual acuity in the left eye was 2/60, and the slit lamp examination showed a white anterior chamber, few cells in the anterior vitreous. So as you can see the fundus, I'll just zoom the picture. You can see here, though they marked it as a vasculitis, if you see this carefully, you can see the whitish deposits over the blood vessels. And you can see varying degrees of the subretinal fluid scattered around this lesion. So the fundus fluorescein angiography showed the hypofluorescence and gradually the dye leaking from the margin of the lesions. And if you can see, these vessels were not leaking the fluorescence. So we went ahead, and you can see here the SSOCT showed this. I'll show you that video where it shows the deposits in the inner retinal surface and the retrohyaloid space. I think it's not playing. So it was showing. So we investigated the patient, and the patient's antitoxo IgG and IgM both were raised, and the patients were started on the trimethoprim sulfamethoxazole combination, clindamycin 300 mg 4 times a day with the oral steroid. And this is the picture in 1 week, 6 week, and 3 months. At the 3-month follow-up, her visual acuity was 6/6. Another case, a 23-year-old healthy male presented with floaters in right eye for 1 month. There was blurring of vision for 10 days, and his intraocular pressure was raised. It was 40 millimeter of mercury when he presented elsewhere. The patient were subjected to investigations like anti-CMV antibodies. IgG was raised, whereas the HSV and visit view was within normal limit. The patient was referred as acute retinal necrosis. So as you can see here, when we examined the patient, his visual acuity was 6/6 and the left eye was 6/5. So slit lamp showed the 1+ cells flare, and the left eye was quiet. And the intraocular pressure, with the help of anti-glaucoma medication, it was 18 millimeter of mercury. And you can see here there was yellowish white granular opacity in the extreme periphery. So I'll just zoom it further, and you can see here there is some areas of the healing you can notice here in between the lesion. And so we started investigating the patients. The patient's toxo IgG was highly raised, whereas the normal IgM was normal. The PCR from aqueous aspirate was negative for all, but it was positive for Toxoplasma gondii. So the patient was started on anti-toxoplasma treatment, and after a month, you can see here, this was the response. The lesion healed completely. So coming to the ocular toxoplasma and viral retinitis, the ocular toxoplasma remains the most common cause of posterior uveitis, whereas the viral retinitis is relatively rare but can be seen in our day-to-day clinical practice. So that's what actually what happens, because we are familiar with the toxoplasma. So we always think of common clinical phenotypes like headlight in fog or satellite lesions. Whereas the viral retinitis, it's basically an umbrella term. There is no definite clinical phenotype with it. It can present as acute retinal necrosis. It can present, various etiology also. It can present due to cytomegaloviruses. It can have a manifestation after febrile illness like dengue or chikungunya. So it has a broad spectrum, and all these terms come under a umbrella called viral retinitis. Now, toxoplasma and viral retinitis, there are certain similarities in them. So both these clinical entities can present as hypertensive uveitis. They can be associated with anterior chamber inflammation, often granulomatous, and they usually have a significant reaction in the vitreous. And another important reason for confusion is the ocular toxoplasmosis in very early stage can have retinitis-like lesions. As you can see here, the toxocyst actually get ruptures from the retinal surfaces, and gradually they go externally towards the choroid. So first there is a retinitis, then it involves the choroid. So at very early stage, there can be inner retinal involvement and can present like this. So I'll just try to conclude with 3 learning lessons to differentiate between toxo and viral. The number 1 is you have failure to identify the atypical clinical presentations. Often we don't pay attention to atypical form like Chilaris arteritis, which usually do not leak in fluorescein angiography, whereas a normal vasculitis will leak. There can be presentation like neuroretinitis, and there can be like the retinochoroiditis around the optic disc, which is earlier known as Jensen's choroiditis. Remember the other differentials of Jensen's choroiditis. These are the TB and toxocariasis. So you have to remember that toxoplasma is not always headlight in fog or reactivation around the scar. Also, you have to remember that certain things are though rare but can occur, like the hemorrhages, uncommon but can be seen sometimes. The pigmented changes usually occurs relatively late in the disease process. And also beware of the HIV or immunosuppressed patients where the toxoplasma can be diffuse and fulminant and can resemble the retinitis. The number 2 is not using the imaging. So you have to imaging in doubtful cases. The OCT can be a very useful tool. This is a very interesting article, and I'll request all the ophthalmologists to go through this article. So this article has given some important points to differentiate between toxo and the viral retinitis. So toxoplasma, ocular toxoplasmosis is characterized by hyperreflective, these oval deposits. And also it can have the round deposits like you can see here in the posterior hyaloid. And in mirror, sometimes it can have this mirror imaging deposits like retinal surfaces, as you can see here with these double arrows. Whereas the viral retinitis, these round shaped deposits are relatively uncommon. Coming to this choroidal enhanced depth in imaging, the ocular toxoplasmosis, the hyperreflectivity of the choroid can be seen beneath this necrotic focus. Also, there can be you can appreciate the choroidal architecture damage, which is characterized by the absence of the hyperreflective septa within the choroid. Whereas these features are relatively absent in viral retinitis, the choroidal architecture is largely preserved, and you don't see any obscuring the underlying choroid beneath the viral retinitis lesions. The number 3, do not treat based on the serological test. The torch titer to diagnose a viral retinitis can be sometimes can be dangerous, because these are the ubiquitous organisms. So mere presence of positive serological test does not mean anything. So for example, I have seen a referral where the test serological, based on the serological test, the anterior uveitis was thought to be a cytomegalovirus anterior uveitis. So you have to do this test very carefully. Always go by your clinical judgment, and in doubtful cases, PCR may help. Thank you.